Hello, I'm Dr. Helen Crawley and I'm the International Medical Director for the Royal College of General Practitioners for Membership and Networks, and I have regional responsibility for South and Southeast Asia. As you know, originally a webinar was set up on quality improvement to address three issues. Firstly, why are twinning partnerships successful? Secondly, what quality improvement tools did we use in our project and how has their use spread and persisted? And thirdly, what top tips can we give for other similar projects? In the light of the COVID-19 pandemic, this presentation has been slightly adapted to look at how quality improvement partnerships can be maintained in these very exceptional times. I would also like to emphasise that the tools used during this project, especially the locally developed peer support quality circles, will provide support throughout the crisis to our colleagues internationally. I think it's also helpful to positively look to the future and to the medium to long term when the COVID situation eventually settles and there is renewed energy for ongoing continuing quality improvement. I would also like to point out that in the light of the global climate emergency, we may also have learned some useful lessons on remote working through this crisis. So to answer the first question, why was our twinning partnership successful? During this presentation, I'm talking about a one-year quality improvement project which was undertaken in Myanmar in 2018 with VET funding. Over the year, 4 visits were taken to Mandalay and Mictala by RCGP trainers. These 2 regions were chosen firstly because they were not Yangon, where a substantial amount of input had already been received. Secondly, we'd already provided training in Mandalay and had a good and positive relationship with the group of GPs there. We'd noticed a positive attitude and an ethnically mixed learning group. And thirdly, we then chose Mictala as it's geographically near to Mandalay but very difficult to access geographically, has had some ethnic conflict issues and is very much more of a remote and rural area. Basically, the partnership worked because it's based on mutual trust and respect built up since 2013. Our clinical lead is a diaspora GP trainer who's been visiting Myanmar with ENT surgeons for a very long time until in 2013 he managed to make contact with the Myanmar GP Society. Since then, a group of RCGP trainers had undertaken workshops with their Myanmar colleagues, attended the Myanmar GP Society annual conferences, including giving presentations on quality improvement and keynote addresses, and we'd also had a number of Myanmar colleagues come to visit us through RCGP Finance travel scholarships to the UK. Together with the Myanmar GP Society, we had a number of meetings with senior health officials, but from 2017 the relationship with the Ministry of Health and Sports became much stronger and we spent much more time with senior health officials together with the GP Society, advocating on their behalf and providing technical support. We've always maintained a 3-way relationship. The Myanmar GP Society has a quality committee which works with objectives which align with the government's national health plan. The RCGP provides technical support to the Myanmar GP Society and advocates on their behalf together with them to health officials and to the Ministry of Health and Sports. In addition, there is a Health Education England project whereby health professionals undertake 6 months placement in Myanmar in a leadership development capacity. RCGP is linked into the IGH Fellow working with the Myanmar GP Society in primary care, and this relationship with the International Global Health Fellow has meant that there's an ongoing presence that we can link with in Myanmar and that links from the more remote areas back to Myanmar Central Committee in Yangon. It also allowed ongoing work after we left and between projects on the Fellows linked project using RCGP quality improvement tools on CPD requirements for the future. So what tools did we use? First of all, we had practice visits. These helped break down barriers between the GPs as they visited each other's practices and realised they were all really in the same situation. And most importantly, we developed quality circles. These were sustainable quality improvement groups which looked at local resource issues, learning issues and provided mutual support. And they've been a real success. I'm sure they will provide invaluable support for colleagues during this crisis, and I'll talk a little bit about them more later. Initially, we expected about half of the GPs attending our training to undertake further training in facilitation and training of trainers so that they could teach future cohorts on quality improvement and they could facilitate the quality circles. In the end, virtually everybody attended this more advanced training, and this meant that both young doctors and the elders could go on to develop quality circles, and it also led to much greater engagement in the quality circles, and basically the GPs set up quality circles in groups that were appropriate to them, either geographically or in terms of their age groups. We did cover a wide range of specific topics. Firstly, we looked at quality indicators. The Myanmar GP Society, in conjunction with the International Global Health Fellow and with technical support from the Royal College of General Practitioners, had written down the sorts of things they might expect to find in a GP surgery. Then 33 practices were sampled by the International Global Health Fellow, and these 3 categories were looked at: the structure, for example, equipment, whether there were any resources for infection control, such as sharp spins or access to hand cleaning facilities. Then the process, for example, whether there was any continuing professional development education being undertaken, what access and privacy protocols were followed, and what infection control techniques were actually used, and the outcomes of care, for example, discussions of patient satisfaction and the concept of audit. We were very clear that these were indicators, not standard. It is not up to the Royal College of General Practitioners to impose standards from the outside. They were just a sampling of the types of care available. Eventually, it will be up to the Ministry of Health and Sports and the Myanmar GP Society to negotiate the actual standards in the future. Talking about the indicators had an immediate effect. Between the first visit in January and the second one in March, one area had set up a sharps disposal system and the other had distributed hand washing posters. And in the light of the current pandemic, the RCGPs are delighted that the local GPs identified the need for infection control as one of their learning needs, and the RCGP supported them in developing learning and resources for this. There were other improvements as well, for example, the use of peak flow meters and their availability, etc. We then talked about identifying learning needs and resource gaps through significant event analysis, patients' unmet needs, doctors' educational needs, and audit, which led to practical discussions and GPs bringing in examples of possible clinical record systems in a resource-poor setting. The GPs attending learnt about personal development plans and practice development plans and wrote their own as part of the project. We talked about recording learning through learning logs, and this has also gone in parallel with work with senior health officials to move away from CPD as sitting in a darkened lecture room and working towards agreed ways to record CPD, including that learnt through self-reflection, self-directed learning and in group activities. We taught consultation skills, which was very popular, and as before we sought quality circle facilitation skills. Eventually there was a visit to the UK by 6 GPs, 2 from the Yangon Central Quality Committee and 2 from each of the project areas, which allowed GPs to witness all elements of infection control. And I'd like to share a quote from a participant. In 2015, you taught us about consultation skills. I've now seen this in practice in the UK. Then you suggested quality improvement. I thought this would be expensive, but we learnt about personal development plans, learning needs and learning logs. These cost nothing. Now we meet in a group and learn from each other. So what were the outcomes of the project? Locally sustainable quality circles were set up. This led to group practices being set up, cross-cover for patients, so there was less use of secondary care, loss of isolation, and I hear from GPs now that they often meet each other in coffee shops and learn from each other informally as well through their learning circles. Nationally, a young doctors movement has evolved, and I'll talk about this more in a moment. There's funding for a 2020 project and ongoing discussions with senior health officials about the nature of CPD requirements. The learning circles are sustainable and the groups are enlarging, with new members joining and new groups being set up in Yangon who don't want to be left behind. In 2018, young doctors ran the first ever GP-led workshop in the annual GP conference, and I saw the flip charts and lots of phrases from the RCPG training all over these flip charts. They've gone on to run their own conference now with 400 attendees, and I was recently sent a poster from the 2019 annual conference with evidence of enlarging circles and areas and topics covered in 20 meetings over the last year. So what are my top tips? At this time of remote monitoring working, the mentoring aspect of the project is the most important, and ongoing mutual support in both directions. The Burmese doctors have strong Facebook groups, and we are now recruiting more doctors who are able to provide one-to-one mentoring and resources in Burmese. We've started to send out some resources, and today I've just responded to a request for that. And the other top tips I have are the exchange visits to the UK, which were extremely successful, the modelling of co-training using trainers of more than one ethnicity during all the RCGP training sessions, and the engagement throughout levels of the health service from GPs to GP Society health officials and the ministry itself. But most importantly, we have set up sustainable local peer support quality circles, which are developing skills for lifelong learning and mutual support rather than focusing on specific illnesses or knowledge.